Okay. So the first general starting point we've taken is that Oleg Chesnov, the ADG and head of the NCD and mental health cluster in WHO, talks about this shift in the way we want governments as a whole to approach NCDs and to approach health, and not be any longer ministries of diseases, but actually be ministries of health. So we try to capture that in part of this transition. And we want to move from really exclusively having the health sector look at a treatment-centered approach to more of a prevention-centered, with doing treatment as needed. From looking at things at the individual level to looking at broader population impacts, from looking at health sector specifically, and even just looking at SDG 3 on health, to looking at how it affects all these other sectors. So this is really what we're going to. The point that we want to get out of the investment case is to have all these other stakeholders at the table, committed, know that it's in their own interest for their core work to do these things. They're not doing it because they're nice citizens and want to help their colleagues who are in health, or even that they just believe in health, but it's in their own interest. So two things. You don't want to apologize for working to improve people's health. I think Jeremy got to that in his presentation, that's an end that's worthy of all of these investments just on their own. But in the meantime, you need to make some other types of arguments to engage some other stakeholders. And so we complement those health-specific arguments with an economic and social analysis. Where does this investment case sit? This sits within a program that we're calling NCD 2030. This is the one I talked about that is about the governance of NCDs. There's 5 steps to this program, first of which is the investment case where we're speaking about today and what we're piloting pretty extensively already. Then we get into the coordination, national coordination, different stakeholders, different agencies, different voices at the table, different roles, recognizing and making sure everybody has a coherent approach to the issues. Then we look at municipal action planning, making sure, just recognizing the fact that a lot of this will in practice be driven by cities and not necessarily by national governments, trying to get the municipal responses ahead of that in some cases where they can bring along the national responses after them. SDG integration, placing this work centrally within the Sustainable Development Agenda, both making sure that the NCD specific targets are central, and then also making sure that the other actions reflect the NCD dimensions of their own work. Finally, when we've got those 4 as the foundation of the work, we get to specific risk factor technical assistance, where we look at how countries can fix their, develop and fix their strategies on alcohol, on tobacco, on diet, on physical activity, looking at more country-specific needs and how to address them. So when we go to countries, who's going and what are the typical roles? Again, we are conscious of being responsive to country demand. So we give general guidelines throughout this presentation, throughout these 2 days, but really if a country comes back and says, this is how we want to do it, then we adopt a different approach. We were in Fiji, and the government was keen to use the investment case to build the capacity of a local institute, so we brought them into it, and they performed some of the research, so we're flexible in how we do it, but generally it breaks down as this. We've got somebody playing a coordinating role internationally and nationally to pull things together, make sure we've got an agenda, make sure everybody makes it to the country, make sure everybody knows their roles when they leave and go home. We've got a lead economist, which is, we hope to find from this group here, generally an international consultant. Usually we have a national economist to support in the country, to bring to the table what's already happened. We're not starting from scratch in most places. We want to use as a starting point studies that have already been done. There may be someone who's worked with WHO on the ground, but generally that's either a consultant who's engaged locally or somebody from the government. It's very helpful, we found, to have a national epidemiologist as well. It just speeds things up. There's a lot of the work that has to be done on data collection. And if we've got somebody in the team who's an epidemiologist who knows where to find these numbers, a lot of this work can be done before we even get to the country. Social development specialists. So this is what Jeremy alluded to, and we've talked a little about it as well. So this is who's going to be responsible for the institutional and context analysis, bringing together these sort of softer political economy issues that aren't necessarily numbers, but sort of the the how. We can look at the modeling being the what and the ICA being the how. We put them together in the end. I'll show you a slide on that as well. Also key to recognize that in a lot of countries, this will be driven by regional WHO and UNDP colleagues. I think in some sense we're a little bit interchangeable, but the global colleagues will bring practices from everywhere, and the regional colleagues will bring their regional expertise, but the regional colleagues can act as any one of these positions. What are the outputs? When we say an investment case, we do mean a report, but it's not just that, and it's not even mostly that. We find that because the emphasis is on advocacy rather than on publishing and peer review and academic rigor, we need to find products that will resonate with a wide audience and that can get the message across in a really short period of time. So we've developed a suite of tools that we think together will generally get the job done. So we do have a report that would be a brief report. We aim for aim for 10 pages, usually get closer to 15, maybe even a little bit longer. But within that, we want a 2-page executive summary. So all of the findings and the political arguments need to be contained on the 2 pages. Then, what I think maybe is the key product for the entire investment case is the slides that we present as a handover, and that we at the end strip off our logos and put on the government's logos, and that becomes the government's presentation. So we've got all the findings, all the arguments laid out in one PowerPoint presentation that's able to be updated, that we hand over, and it should be tight, clear messaging, clear findings, not too many words on the page, and really presented by someone who knows the findings, where it came from, and is keeping in mind the messaging. The Excel-based model. So yeah, we need to hand over the data so that they can either play with it, verify it, and redo it later on. An infographic or other advocacy materials illustrating the main findings. In Kyrgyzstan, there was a roll-up, one of these posters that goes from the ground up that had the main findings. We do infographics so that they can be shared on social media. In Georgia, we're going to do a brochure that's just a A4 folded with the key messages that we can hand out, so when you're talking, someone can be flipping through, halfway listening to you, but also halfway looking at the findings. We also recognize that we're never going to have anybody's full attention, especially if we're meeting with a president or a minister. They may be listening, but also need to use the time that you're talking to familiarize themselves with the context. Then we want to have a tailored support plan for communications for the government. When we give it to them, we're not just saying, here you go, goodbye. We work with them to say, here's how you may want to publicize the findings. Here's how you may want to use this to influence other members of the cabinet. Here's the a generally tailored and specified plan for using the investment case. Process. When we first drew up how this would be done, I think we had a 6-month process at least, or 18 months, or something crazy. The countries aren't asking for that. They want the finished product. They would rather have some compromises on how extensive it is and have it in their hands than than be waiting for a great product that's going to come sometime in the future. So we've been working to reduce the process down to a point where we can say, okay, we start data collection, we go to the country, and then just a matter of a few weeks later, we come back and hand it off and move on. In practice, it's widely varies of how much it takes, mostly based on the timing and the requests of the government. We were set to go to Nepal recently, and they said, well, we've got elections coming up, so wait till January. These things happen a lot. There'll be floods somewhere, and we're delayed by that. So we recognize that, but we want the process to be set up so that we can get in and out of countries quickly. We have a lot of countries we need to deliver for, and if we get stuck in each one for 18 months, we're never going to finish them off. So what do we do? When we agree and we've got the funding, we've got the team, we start with remote data collection and essentially some conference calls between global, regional, and country. Then in country, there'll be some coordination meetings, but the data collection can start in earnest before anybody gets to the country. In practice, it's harder. The governments aren't always so keen, even though they want the finished product, having them release the data to you is a lot harder. So a lot of times that does involve going there, sitting across from the table, talking to them, showing them how you're going to use it, bringing them into the conversation. Then the data starts flowing. But in theory, in some countries, a lot of the data can be collected beforehand. A lot of the analysis can be done. But we do need to have a first mission. So we have this first mission where we brief stakeholders, we make sure everybody knows what our objectives are, how we're going to use it. We use this as really one of the main objectives of the meeting is having these initial meetings with these other sectors. We get a chance to sit across the table with Ministry of Finance, explain to them in a short 1 hour meeting why we're doing this, what we're trying to prove, sort of priming them for those ideas, convincing them that it's in their own interest, it's part of their work. So we have the stakeholder engagement, we collect data also, and we tend to split up in different tracks when we get to the country. We have these sort of political discussions, and then we have the data collection discussions, and we split ourselves up into a couple teams. Meanwhile, the stakeholder engagement meetings can be interviews for the ICA that we do at the same time we're doing this. We do the first mission, everyone goes home, then we do our work. We do the analysis, we prepare those 5 products, get ready to come back. We start to verify it and validate it with the country. So as of, I think, today or probably Monday, we're sending off Georgia to the Georgia Ministry of Health saying, here, have a look at this. This is what we're going to likely present when we get to you. Then we have the follow-up mission. This is a shorter one. The first one, we're aiming for about 4 working days to do all that. The second mission can be usually 2 or in some cases even 1. We have some kind of a stakeholder meeting where we try to get as many eyeballs as we can, as much attention as we can. Whether it's a cabinet meeting or a public event, we try to just present the findings and get them publicized as broadly as we can. And we also have some dedicated time specifically with the Ministry of Health to go through and the fine details and the findings, how they use it, to really have this handover process. And when we do that, we're finished and we're on to the next one. Audience, as I said, the audience is not the Ministry of Health, it's really these other ministries. The Ministry of Health, where it's written for them to present. That's the way we see it. And again, it's up to each country, but we're not trying to convince Ministries of Health because they already get it. So it's really getting beyond that, helping them to convince the other sectors. We're trying to get to the calculations of the cost and the burden of both NCDs and tobacco use. And you'll see that we have a couple of different streams for these things, and we have a little bit of a different methodology for tobacco control specific investment cases. I wouldn't worry too much about that now for 2 reasons. Really, it's an arbitrary division anyway, and most of it comes from different donors who have different preferences. And in the end, we hope to align them so that the division between the two is invisible. We don't want to go to a country and do an NCD investment case, and then 3 months later go back with mostly the same people and do the same work again and convene the same meeting. So we hope to align them as much as we can. But the principle is they need to be nationally owned, and that's why we respond to that demand. Replicable so that they can continue to take them forward every couple of years as new data comes in, tailored to their needs and simple. And we will have to make compromises. We know we bring in really most of the most accomplished health economists that there are. And I think it's important to recognize the compromises that you're going to be asked to make by us from the beginning. We're going to tend to prioritize speed and simpleness over the depth you would normally be comfortable working in. And it's a constant give and take. And I think even the most recent time I've asked for these compromises was during the coffee break. I sent an email to some colleagues saying, okay, don't add these extra components, just give us what you've got, it's good enough, let's go. So that's the sort of message you'll get from us when we really get into it. 2 parts, I think we mentioned the modeling, where we look at the burden of NCDs, both health and economic. We look at the interventions that may be prioritized, we cost them and look at the impacts of them, and then we look at the return on investment of those interventions. So that, combined with the ICA, is your investment case. This makes it seem like they're 2 equal parts. They're not really. The ICA is a sort of a complement to it. It really, the findings of it are infused into this broader modeling and argument development. But there are 2 parts. 4 discrete steps. where do we start? What are we looking to have by the end? The first one is estimating the economic burden of NCDs. We've got that, and that's both direct cost to the health sector and indirect broader economic productivity losses. Then you've got to estimate the cost of these interventions. And this is a bit of a political discussion about how do we choose the interventions. We've got to understand what's already happening, what, there's political space to implement. We look at a usually somewhat narrow range of interventions. We are guided by the WHO best buys for NCDs. But I think I saw in Kyrgyzstan there was something like 17 that you guys were able to cost, and that was really good. I think in other places we may end up with 4 recommended interventions that we look at. We look at the impact of those interventions, the cost of them, the cost of implementing them. Most of these are policy interventions, so they don't have a huge cost. It's just changing policies. But we do have a way to cost even that. Most of the investment is political investments, political capital, less than just scaling up huge programs for lots of people. So we estimate the cost and the impact of those interventions, and then we quantify that return on investment, and that's one of the key numbers that the Ministry of Finance would want to see. Okay, if we do this, here's the intervention you want to do, what would be the economic impact of that? And we look at that in terms of the broader economy, we look at that in terms of revenue for the government, and we look at that in terms of the health dividend as well. We don't want to forget about the health arguments. This is just to show that, and this is a little bit outdated, but we don't try to do everything. The green numbers here are what we started with, and some of these we don't even put into the model. I think usually we don't count care. If a person gets sick who works and leaves the workforce, and then it's the responsibility of a spouse to look after, or your adult child look after them. A lot of these knock-on effects we don't put into it at all. So don't go into it thinking we need a comprehensive overview of everything. We want a snapshot of the main influential costs and impacts. What are we trying to get to? Here's this slide where we try to have all the main key arguments we want to make expressed here. So we want to be able to say, these are the number of people in this country who have an NCD or multiple NCDs. This is how many people die each year from that. The costs of those diseases and death are this in direct costs to the government or to the health sector, and here are the indirect costs from productivity losses. We can then show those losses together as a percentage of GDP annually that's lost each year. And this tends to come up, and the country's done relatively consistent. And we're looking at, if we take out Fiji, which came out really high, take out that, we're looking at between 3.5% and 5.5% for the most part, and which is a huge part of GDP that's lost each year. We won't be able to recoup all of that because there's a lot of other factors. These things change very slowly, but if you even take a part of that, it's enough in some countries to tip the scale from a contracting economy to a growing economy. And where we can make that argument, it's really persuasive for ministries of economy, ministries of finance, for heads of state. So we use those GDP numbers wherever we can. And then we compare those losses to the costs and the benefits of doing these interventions. That here's the money it would save from the government, here's how it would grow the economy, and here's the lives it would save. The return on investment, and then is that sort of final number where we've got everything, here's where you do it. And when you end up with a really persuasive ROI, it makes it that much easier to get people committed to the policies.
Dudley, just so I just get an idea, how much more have you got of these?
I think I'm done. So these we can go through later in more detail.
We're going to go through in more detail with Jeremy and others.
We should also show case now.
Yes. Okay, good. So I'll leave it one more slide. This one, just to show these are the countries. We haven't done any, there hasn't been a call for proposals or expressions of interest. This is just word of mouth and us being around doing it. And we've ended up with this many governments requesting this already. We have funding for probably an additional 20 of these already in our pockets that we need to get moving on. And we assume that by doing a good job on those countries that we'll find funding to finish off more of these. And it may be that we end up with another 40 countries who ask for it. So it's really more demand, organic demand, than any project I've worked on. So we're keen to make sure we can get in and out of as many of these countries, delivering sound products for them as quickly as we can. Okay, thanks guys.
Okay, that's great. Thanks very much indeed.